Thank you very much, sir. Okay, so are you seeing the big screen now, or are you still seeing the small screen? You
Yes,
should see
sir. Now it's
you
okay.
okay, that's fine. Brilliant. Okay, go on, please. If you can use the mouse for scrolling, or you can scroll using I think the arrow keys also work.
Uh,
Oh,
I'm
yeah,
requesting it again because I cannot
yeah.
scroll.
Okay, I've just approved it.
Thank you. Okay, so I'm going through the images first.
Yeah.
I'm being presented with lumbar spine MRT, two weighted images sagittal of a patient who have been presented with pain. First of all, I'm going through the images before describing them. So I can see that the marrow signals appears normal. There is no abnormality in the marrow. The disc species appears intact. Now I'm looking at the conus. The conus is also ending at L1. So I'm checking the spinal canal. So there is no stenosis of the spinal canal. I'm looking at the there is slight edema is seen one of the pedicle of the vertebra like L2 or L1.
Okay, so
So
I'm going to give
I'm
you, I'm sorry, I don't mean to interrupt you, but I'm going to give you tips while we go through this process, okay? If, for example, let's just say you are in the exam, okay, and you catch something that you're talking about and the examiner wants to move away from it, he'll just say something like, no, don't worry about it, okay? So point
okay.
out where you saw the edema at the L2. It's just to let you know, I'm not trying to be rude. I'm just trying to tell you that I don't think this is where the abnormality is. So if you can point out where you saw the edema in the pedicle, I'll just scroll through it.
Okay, so I'm suspecting here.
Okay, so a couple of things here. Okay, ignore this for now. I don't think this is edema. Go
Okay.
on. Okay, we'll come
So
back
I
to this.
can see that there is slight hyperintensity signal in the superior end plate of LV5. So I'm suspecting hyperintense signal due to shiny corner syndrome. So this may be due to ankylosing spondylitis. So I will further want to evaluate this patient on further sequences. So can I have start signal or?
Okay, so as I mentioned at the start, there is no stir. There's only these three sequences. You've got T1, T2, and axial T2.
Okay, so the same area appears a low intensity on T1. So I'm also trying to look at this area on axial section.
Okay, I'll bring up the axial section as well. There you go.
Okay, so now I'm looking at the sacroiliac joints. So images are a little bit jumpy. So I'm just trying to, can I scroll via the key? So
You
it may
can,
not
yes,
jumpy.
yeah. You can use the up and I think it's either the up and down keys or the side to side keys where you can scroll. Yeah.
Okay, now it's okay. So I'm going through the image again to look at the sacroiliac joints. So here I can see that there is slight widening of the sacroiliac joints with slight erosion or irregularity of the margins of the sacroiliac joints. I'm just trying to look at the same area which I have seen on sagittal images. There is no spinal canal stenosis or narrowing. The neural foramina appears ample, and so I'm suspecting again ankylosing spondylitis. So I will check the clinical history of the patient. If the patient has any previous history or any previous imaging to look for the presence of the same lesion, and
Okay, this is a patient who's been referred by their family physician with query low back pain, occasional radicular symptoms, but no specific neurological findings. There is no previous history otherwise present for you to evaluate.
okay. So I'm also checking the rest of the like there is the psoas tendons on both sides appears unremarkable, and so okay, so I will convey the finding to the referring physician, and further discussion with the rheumatology team is suggested in this case for further management. I'm suspecting in this case ankylosing spondylitis.
Define further management for me, please. What do you mean when you say further management?
These patients are seronegative ankylosing spondylitis, is a seronegative spondyloarthropathies. So, like immunomodulators, I don't know exactly the treatment of ankylosing spondylitis. So I will
Okay.
refer the case to the rheumatology clinic for further management.
Okay, I'm going to take back control of the mouse. I'm going to bring you to another. I'm going to show you another case. This is also a patient who's been referred by family physicians for back pain, generalized back pain. Okay, there are multiple sequences. I want you to start off with, sagittal T2 weighted sequence. Okay, and
Okay.
what I'm going to do is to make your life easier. I'm also going to put actually, I'm going to put a stir and I'm going to put a T1. So on the left side of the screen, you've got T1. On the right side of the screen, you've got stir. Okay. Tell me what you
Okay.
think.
Okay, so in these provided images, I can see that there is low intensity signal is seen, which is involving the vertebral bodies of the upper thoracic vertebra. In my routine practice, I'll count the images. So this is low on T1 and high on T2 weighted images. And so there are multiple vertebrae, like I can see that it is involving at least two vertebrae in the thoracic region. Now I'm looking at the spinal canal again.
Mm-hmm.
Okay, so there is no lesion within the spinal cord in this area, in the visualized region, and the high intensity signal on T2 and low on T1 is not extending into the posterior elements. So so I'm suspecting this could be. May I know the age of the patient?
Patient is 20 years old.
Okay, 20 years old patient, multiple high intensity on T2 and low intensity on T1. This could be due to any metastasis is like less likely in this young age patient. So other possibility is the patient have any history of carcinomas, so these may represent metastasis. So I will further evaluate this patient. Rest of the images.
Okay, I'm going to show you some more selective images. Okay, I've got a sagittal T1 and a sagittal
Okay.
stir, again through the lumbar spine. And in regards to your question regarding further history, the only history we have available and this is a real case which I myself have reported. The history is just back pain coming from a family physician for a 20-year-old patient. That's the only history you have.
Okay, so again, I'm going through the images here. Again, I can see that there are multiple abnormal signal areas are seen within the vertebrae. So I can see that again, there's areas of low signal on T1 and high on T2 in multiple lumbar vertebrae. So again, suspecting um, like these most likely due to metastasis.
Okay.
So I'm looking again in the spinal canal. Yeah, I can see that this in the lumbar region, it is also extending into the posterior elements, and there is no disc space narrowing again, and the conus
Okay.
is ending at its normal anatomical location. There is no stenosis. There is no disc protrusion or
Ignore disc protrusions, ignore disc herniations, okay? This is just
okay.
back pain. Okay, let's ask some questions. Let's go back to, let's stick with this, okay? So this is because now you are expected to answer some questions on not just management, but also in terms of like, some basic questions regarding the cases. How do you define low signal within the vertebral bodies?
Um, because I can see that on T1 weighted images, the vertebral body signal should be more than the intervertebral disc in these areas, like in the lumbar vertebrae, which I mentioned. The signal is less than the intervertebral disc. So, and
Very
that's why
good.
I'm suspecting that this is abnormal. And so this needs to be further evaluated with the CT cap, like
Okay.
CT chest, abdo, and pelvis for further management.
Okay. How about this case? Scroll through it slowly and see if there's anything else that gives you a clue what this patient might have. Have you looked at all the
Okay.
findings?
Okay.
Take your time. There's no rush. Have you looked at everything?
I'm looking at the again vertebrae and the
Just stop
spinal
there.
canal.
Just scroll. Let me just scroll this. Okay, just stop there. Is there anything else that is catching your eye
Um, uh,
in the
I'm just
spine,
looking
outside
at
the spine?
the, yeah, so I'm looking at the prevertebral region. So here I can see that there is an abnormal signal which is present in the prevertebral location. So in my routine practice, I'll also check the axial view to look for the or any localizer to check for the presence of any abnormality in this area.
We have only one axial through the thoracic spine.
Okay. So I'm again going through the images. So here I can see that there are abnormal signal in the within the intramedullary region of the spinal canal. Um,
One last question on this case because I want to show you more cases. Any other cause that you can think of besides metastatic disease in a 20-year-old chap with multifocal bone disease?
this could be due to metabolic bone disease. If the patient have any history of um, metabolic causes like hyperparathyroidism or um,
Okay, we'll come back to this on the feedback. Don't worry about it. Okay. Now I'm going to show you X-ray. This is a 59-year-old chap, okay, who's complaining of right shoulder pain. Okay, the referring orthopedic surgeon requested bilateral side for comparison. but his symptoms are on the right side, okay? So it's the right shoulder pain. Have a look at the x-rays and see if you can see anything, or if it's normal, just say normal.
Okay.
59-year-old male.
Okay, so I've been presented with the X-ray AP view of the shoulder joint of a patient who have been presented with shoulder pain. First of all, I'm going through the image. So I am just trying to look at the humeral head. There is slight lucency which is projecting over the greater tuberosity. It may be projectional. I will confirm it on the further image. Going through the clavicle and acromioclavicular joints appear normal. The normal congruity of the glenohumeral joint. I'm looking at the scapula. So at the medial lower border of the scapula, I can see there is a soft tissue density area which is
Completely ignore
projecting.
it. Ignore it.
Okay. So now
Ignore it.
I'm
It's just
looking
projection.
at the lung. Um,
Lung is
so
fine.
I'm suspecting small lucent areas which are present over the vertebrae. Oh, sorry, ribs.
Vertebrae.
Yeah,
Ribs,
sorry,
no.
ribs.
Ribs are fine.
Okay. So I'm looking at the soft tissues in the supraclavian region and in the, okay.
This is the scapular view. If you can't see anything, just say can't see anything.
Okay, so I cannot find any abnormality on these provided images.
Okay. So the patient is in a lot of pain. There's no history
So,
of trauma.
okay.
The
Patient has
patient is
history
in
of
a
trauma.
no. Patient is in a
Okay.
lot of pain. No history of trauma. Okay. And
Okay.
he's in a lot of discomfort. The physician says, "What now?"
Further
What?
evaluation with
Yeah.
MR, in this case, the patient have pain.
Okay. All right. So we decided that we were going to do an MR. Okay. So I'm going to bring up this MR. Okay. Okay. So I'm going to show you an ax. Hold on. Sorry. Let me just scroll, please. Just let it go. Okay. I'm going to show you an axial, and I'm going to show you sagittal. Tell me what you think.
So these are not scrollable.
These are scrollable.
Okay. First of all, I'm going through the axial images.
Mhm.
So I'm looking at the marrow signal appears quite heterogeneous in the humerus.
Marrow signal is absolutely fine.
Okay. So I'm going through the muscles. So the biceps and the supraspinatus muscles appears unremarkable, and I'm looking at the joint space. There is no effusion within the joint space, and okay, so the supraspinatus, I'm looking at the supraspinatus on sagittal images. There is slight edema and a different increased signal is seen in the subscapularis muscle. So there is no atrophy of the muscles I can see. So I'm just suspecting edema in the subscapular location of the muscle.
Okay. Is it subscapularis? Are you sure?
I'll check it again. So this is supraspinatus, this is infraspinatus, and this is subscapularis.
That's the tendon of the subscapularis.
Yeah, tendons of the subscapularis muscle.
but it's not involving subscapularis.
Okay.
What's going on? You need to describe it for me, please. I know you're saying that there's some edema, but there's a little bit more than that. What's going on?
Okay.
Where is it in terms of
So,
location?
so it is at mm,
Okay, forget the anatomy. Do you
okay.
know the diagnosis? The reason I'm asking you this question is because obviously you've spent about 20 minutes, and I want really ideally would like to show you one more case, and we'll then talk about the feedback. Okay?
So
So,
this could be due to um, just suprascapular or infrascapular nerve impingement, which is causing this pain as the
okay, if
patient
you
has
just
edema.
scroll up, scroll up, stop there. Okay, no, come down, come down, come down, stop there. No, just one slice up. Okay, stop. No, no, one slice down. Just one. Hold on, let me do that. Okay, hold on. Okay, I'm going to show you that image. And no, 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 don't scroll. I'll scroll. Okay. I'm going to show you that
Okay.
image and I'm going to show you this image. Just these, don't scroll. Tell me what you think.
Okay. So um, I cannot recall. Sorry, sir.
No problem. No problem at all. Okay, I'm going to show you one last case because I want to get I want to get you to see as many cases as possible. Obviously, you will observe with others as well, but I want to show you one last case, which I think would be a good learning case for all of us. Okay, so this is an 11-month-old child who's been brought by her mother to A&E complaining of left arm pain.
Okay. So I can see that there is a mildly displaced spiral fracture, which is through the humeral head. Sorry, humeral diaphysis.
Mhm.
So I'm suspecting um, physical abuse in this case, as a patient has patient is a toddler. So this is not weight bearing area. So I will
Okay,
immediately convey the finding to the referring physician, and child protection services should be informed, and further skeletal survey in this case is suggested to look for the
okay,
presence of any other fracture. So now I'm also looking at the ribs for the presence of any fracture.
okay.
Um,
The mother
so
is
there is
adamant. The mother is adamant that she would never hurt her child. And she's saying, nope, you're wrong. Is there anything else that suggests that this may be an AI case?
in the one of the rib on the left side also appears expanded anteriorly. So I'm suspecting. So I need further X-rays to just confirm of these findings.
Okay,
And
okay. All right, okay, we're going to stop there. Okay, well done. I think, okay, so let's start off with this case. We'll go in reverse. Is that okay?
okay,
All right, okay, so this is for those who are observing and obviously for yourself as well, this is a classic case of a non-accidental injury. 11-month-olds, you see bucket handle type fracture of the metaphysis, spiral fracture of the humeri, this multiple rib fractures of different varying ages. This is NAI. And your management, you said the management was correct. You have to call the physician, pick up the phone, give them a call and say, hey, the child should not leave the emergency department. This is NAI till proven otherwise. We need to do further evaluation, get the social services involved, etc., etc. Now, the question I can ask you is, well, is there any other evidence? And you're correct. There are rib fractures here as well. For those who cannot see, I'm just pointing it out. Anterior end of the third rib is fractured. Anterior end of the fifth rib is fractured. Sixth looks a little bit dodgy, but difficult. But the third and the fifth are certainly fractured. And more importantly, there is a heel fracture deformity of the right clavicle as well. So this child, unfortunately, has been abused in the past as well, and he's got multiple fractures of varying ages. Okay, NAI till proven otherwise needs to be informed. The clinician needs to be informed. For this case, I've given you a clear pass. For excellent, I guess you would have had to. I mean, obviously, I understand the time is a constraint for you, but I would have expected for excellent for the person to actually pick up all the findings and then say, all the relevant management points as mentioned. Okay. The second last case. Now this is actually, oh, sorry, is this? No, this is not the case. It is, sorry, where did it go? Yeah, okay, hold on. Where did that go? Sorry, let me just find that case. Okay, we'll come back to that. Let me just find that case. Let's go to the first case because we don't want to spend our time. Okay, so this is a good case, and you kind of like nailed it in the sense that you picked up the most important finding in this patient, which is that this patient has got um, uh, ankylosing spondylitis, or at least signs of ankylosing spondylitis, because obviously we were short of a little bit of time because I wanted to. Now, a couple of learning points for all of us, okay? You don't assess marrow signal on T2 alone, okay? Yes, you obviously look at the marrow, but the important sequence is T1, okay? And T1 clearly shows that there are areas of low signal intensity at the anterior corners at L1, L3, L5, okay, and even at L1, okay, and these correspond to bright areas on fluid sense on T2 weighted images. So these are concerning definitely for inflammatory arthropathy, okay? So you definitely picked it up. In terms of, I've given you just pass for number one. You kind of like spent a little bit longer than I would have wanted you to spend on it, right? You were kind of dithering a little bit. So you need to be a little bit more, straight to the point. The second thing was you were struggling and you were like, oh, where am I seeing it? And am I seeing it or not? And so on and so forth. SI joints are abnormal in the sense that there are these areas which are either foci of hyperintense signal. You can't tell whether this is bone marrow edema related to enthesitis, okay, or this is fatty infiltration related to periarticular fatty changes that can occur second to fat saponification, okay. So I wasn't very convinced with the erosion part, but they do look abnormal, okay. And in terms of management, right, what would you recommend this patient have? You would say, you said rheumatology referral. The rheumatologist, you can say patient needs correlation with HLA-B27, okay? And I can again ask you questions on HLA-B27 because HLA-B27 is falsely positive, I think, in 10% of the population, and it's not always present, okay? And the other thing that you can recommend is imaging of the sacroiliac joints for more definite confirmation, okay? So you pass this case, but you can do a little bit better, okay? The next case is actually, you kind of, unfortunately, I had to give you a borderline fail. And the reason for that is you picked up the abnormality, but you couldn't give me the right differential. And so there is a couple of things here that stand out, okay? There is multifocal bone disease, okay? So there's changes in the thoracic spine, and there are changes in the lumbar spine as well. But there's also something else going on. There's a lot of extra osseous soft tissue disease here in the sacral region, lumbosacral region, and also in the thoracic spine. This is all extra osseous soft tissue disease here, which you can actually appreciate even on T2. This is not normal. And the third thing that this patient has got is they've got a lot of mediastinal soft tissue disease. Okay. So this is all lymphadenopathy. And because the case does require a little bit more observation, there's a lot of soft tissue here anteriorly in the lumbar spine. These are all lymph nodes. Okay. So does that change your differential now that you've seen this?
Yeah, lymphoma can present like this.
Exactly. So this is lymphoma. Okay, this is lymphoma. This is a case of lymphoma. The two differentials for this case would be lymphoma was the differential and it turned out to be lymphoma. The other case that you can sometimes give, and it would be pretty reasonable as well, would be tuberculosis. Okay, but tuberculosis, usually the disease is more, there's a lot more fluid component. There's obviously, there are no end plate changes in this patient, which would be, more typical of TB spondylodiscitis. And even though you do see multifocal disease with TB, right, it's not as widespread. So this is very much like a lymphoma, okay? But you went down the tangent of metastatic disease and metabolic diseases. Those were completely, unfortunately, the wrong differentials. So even though you described the case, the findings were not all there. And more importantly, your differentials were not appropriate. So this is a lymphoma case and it needs to refer to the hematology MDT. Okay. You did answer the question in terms of whether the patient had, how do you define low signal on T1? And correct, it is defined according to the disk space. If you don't see the disk space, then what's the other criteria that you can use? Do you know?
We can use muscle,
Correct.
muscles.
Correct. So it's either going to be the disk space, or you can actually compare to the muscles, okay, to sometimes get the right answer. Now, this is actually an interesting case for two reasons. It's a bit tricky, but let me go to the MRI first, okay? So the MRI is actually quite classic, okay? This is calcific tendinopathy of the origin of the coracobrachialis and short head of the biceps, okay? So that's why I was trying to get you on the anatomy part. So if I show you the sagittal, okay, this is the subscapularis muscle, okay? There is a bit of fluid anterior to the muscle, but the tendon is fine. And this is where the edema is centered at, okay? This is calcific tendinopathy, okay? And it's kind of actually interesting for me as an MSK radiologist, because we see these calcifications and we kind of like, yeah, they're minor calcifications, but if the patient is in a lot of pain, then these calcifications can be a source of pain. We see it particularly in unusual occasions where we kind of like ignore it, and it turns out that, hey, we shouldn't ignore it. I've seen it in small joints of the thumb. I've seen it in here. I've seen it in ankles, where even I've seen it in pes anserine tendons, literally tiny eeny calcifications, but they can literally cause a lot of edema and inflammatory changes around it. Okay, so this is calcific tendinopathy of the short head of the biceps and coracobrachialis. They arise together. Okay, and this is what it was involved. It's not subscapularis. So again, just the learning point from anatomy perspective, know the muscles, know the anatomy a little bit, okay? And if you see a dark area in the tendon, check for calcification, okay? It is, in a certain sense, it is actually kind of visible. I know I'm being a bit unfair on the radiograph, but it is kind of visible just right there. The question that I would ask if I was an examiner, I would say, okay, I can't see the calcification. How do I confirm it is a calcification? Well, you can actually look at gradient echo images, and that gradient echo images does show calcification. Or you can do an axillary view of the shoulder, and sometimes you may be able to pick up the calcification near the coracoid process. Okay, but this is calcific tendinopathy. It's a pretty standard appearance. So when you see that, just make sure that you know the anatomy and you call it out. Okay. Well done
Okay,
otherwise.
thank you, sir.
Oh,
Thank you.
just last point in terms of communication, because obviously that is now a part of the exam. You are absolutely fine, but when the examiner is talking, right, don't try and talk over him. Just be patient. I know it's a very tense situation, right? You've worked very hard for months, and it's like, your life is like dependent on it, and you want to pass that exam and you don't want to fail it. And I hope nobody fails it. But if the examiner is talking, right, examiner is not there to cheat you, not there to make your life harder, not there to, make life difficult for you. They're trying to give you a hint. They're trying to bring you back to the right place. So don't try and talk over the examiner. If the examiner starts speaking, say, yes, please go on, or sorry, my apologies, you were saying something, and just let them get back on the track, because they'll either say, no, this is not relevant, or this is the history, or have you looked at something else? Because in your nervousness, what will happen is the examiner is trying to give you a clue. You may miss it because you're not paying attention, right? And that's something that you need to keep an eye out. Okay. But otherwise, well done. Thank you. Okay. Candidate number 2.
Hello, sir.
Okay. Candidate number 2. I've just noted out the time you're starting, and I'm going to give you the first case. Let me bring up case. Okay, let's start off with this one. Okay, so this is a 66-year-old patient complaining of pain in the left hand.
Okay.
You may
I'm
need
presented.
to you may need to get the controls, or I can just take the controls so that in case if you need to scroll through the
Yeah.
images.
Yes.
Okay, all right. Please go on.
Yes, sir. I'm provided with the frontal radiograph of the hand in a 66-year-old male who's presenting with complaints of pain. So I can see, okay, in the given radiograph, I'm trying to visualize um, the different the bones which are seen. So that is, I'm trying to see the phalange, the metacarpal, the proximal phalanx, the mid as well as distal phalanx, which wherein the bones appear relatively normal, but I can see that there is some kind of soft tissue density which is present at the level of the proximal interphalangeal joint of the little finger, which is probably long standing because I can see that there is some kind of scalloping which is present along the dorsal aspect of the mid phalanx. So I cannot see any calcifications or any differential densities at this site. So to further evaluate it, I would like to go ahead with MRI of this patient.
There is no MRI available. This is the only imaging you've got. Tell me what are the differentials.
Yes, sir. Given the age of the patient and the location, and I cannot see any kind of differential densities or calcifications which are present. So, primarily, and it is a long-standing lesion along the dorsal aspect. So, I would be thinking in terms of giant cell tumor of the tendon, which can cause, because it is kind of long standing and it can cause the scalloping along the posterior aspect or mass effect over the bone along the dorsal aspect. Then any traumatic, if the patient has any history of trauma, then chronic long standing hematoma, but that is relatively less likely, or any cyst like epidermoid cyst implantation, which is present over a long period of time, can also cause this kind of appearance. Then, because it is a dorsal, along the dorsal aspect, I'm thinking more in terms of tendon pathologies. So I think my primary differential would be pathology related to the tendon, that is giant cell tumor or giant cell of the tumor of the tenosynovial giant cell tumor. Sorry.
Okay.
I would, yes, I would like to know from when the patient has the swelling, since how long he's been having this swelling. And I would also like to correlate with ultrasound, even if MRI is not available. And I would like to convey the findings to the referring physician and also to the orthopedician, along with further imaging for coming to a definite diagnosis and for the management of this patient.
Okay. All right. Let's dissect what you've said. You said, first you said the bones appear normal. Do you think the bones appear normal? Just yes or no?
No.
The bones don't appear normal. Okay, we agree on that. Then you said the appearances of the bone are chronic. So what would be the features of chronic? So here's my question to you. First question that I want to ask you. Do you think something is happening in the bone, or something is happening outside the bone, or something may be happening in the bone that's extending outside the bone?
Yes, sir. For the first question, I was thinking about a long-standing cause because
Mm-hmm.
I can see that a uniform kind of concavity is seen along the posterior aspect of the bone. The second question of whether I was thinking it is an intra-osseous pathology or an extra-osseous pathology. I am thinking in terms of extra-osseous pathology or soft tissue pathology, because if it was an intra-osseous pathology, I would be seeing there will be an expansion of the medulla some kind of cortical changes, and if it is especially if it's extending to the soft tissues, there should be some giveaway of the cortex. So I'm not seeing any changes which is there within the bone to show that it is an intraosseous pathology which is extending outside into the soft tissues. So given
Okay.
these features, wherein only I can see the cortex is intact, there is no periosteal reaction, there is no expansion of the marrow, and there is a scalloping along the dorsal aspect, I am thinking of a soft tissue or extraosseous pathology, which is being long-standing, thereby causing a mass effect over the phalanx,
Okay.
mid phalanx.
Do you see sclerosis in association with this abnormality? Do you see
In
sclerosis
this
in
present,
association at the bone? Do you see sclerosis?
do I see sclerosis, sir? Is that
In
the question?
association, yes. You're saying it's a long-standing abnormality. Do you see
Yes.
sclerosis in the bone?
No, sir, I'm not seeing sclerosis in the bone.
Would you agree with me that there is periosteal reaction going on there?
Yes, sir. Now, yes, once image is magnified, I can see that there is a small,
Would
tiny,
you, okay,
yes,
would you agree that the margin of the bone is ill-defined?
yes, sir.
Would you also agree that there is some intramedullary change going on there? That the bone density is different in the
It's,
proximal 1/3 compared to the distal 2/3?
yes, sir.
Okay. The
So,
history is
yes,
this is a short, very short duration. Literally, he's been complaining of pain for 2 months. No history of trauma, and he has just come in, and this is the X-ray.
okay. So then considering it to be an acute history, and there is the age was also 66-year-old. Another possibility can be that of, and also soft tissue swelling is there. Um, though it is an atypical site, I can also think of gouty arthritis. And
Okay.
since he's having severe acute pain as well as swelling, considering the age and the bony changes along with soft tissue edema, gouty arthritis can also be a possibility.
Okay. All right.
So
We
I
will
would
come
like,
back to this case. No, we'll come back to this case
yes.
because I want to make sure that you see many cases before your time is up. Okay. All right. Okay. Let's have a look. Okay, we'll go to this case. Okay. Okay, so you have a patient who has bilateral foot pain, and I'm going to actually just show you this image first. Tell me what you think.
Bilateral foot pain, sir.
Yes, bilateral foot pain.
Yes. Okay. So I'm presented with a radiograph of bilateral foot, and since I'm with a patient who's provide with a history of foot pain, and I can see that especially at the level of both the intertarsal joints along the medial aspect, I can see that is the medial cuneiform as well as the navicular bone. Some amount of sclerosis as well as some subchondral cystic changes are seen in both the left as well as the right foot, predominantly on the right side. The rest of the visualized tarsal bones are appearing relatively normal, and I'm trying to look at the joint spaces. They are also appearing relatively normal, and the alignment I'm trying to see. There's no history of trauma, but alignment was also appearing relatively normal. I can see a bipartite medial sesamoid, which is there at the base of first metatarsal. So, considering, I would like to know the age of the patient
60
because
years
given
old.
these findings, 60.
60 years old.
So,
Okay, so here's a
uh,
tip. Okay, stop.
yes, sir.
Here's a tip. Okay, you've asked a question. Let me answer the question. Okay, this is for all those candidates who are sitting the exam. Okay, you asked me a question. I would like to know the age of the patient. And even before I've answered it, you started talking again. Once you ask a question, look at the examiner, The examiner may either give you the age of the patient, give you the information that they are going to give you, or they may turn around and say, which I sometimes say, sorry, that has to be earned, not given. Okay. So if you ask a question, slow down. Okay. Stop, wait for the answer. If you're not getting the answer, they will either politely decline or they'll give you the answer if they think it's relevant or it'll help the case. Okay. Go on. Tell me what you think.
Sure, sir. So, given the age of the patient, which is 60 years old, I would like to think in terms of degenerative arthritis,
Okay.
predominant, yes, predominantly involving the midfoot because of the sclerosis, subchondral cystic changes, which is very evident along the intertarsal joints, predominantly along the navicular as well as the medial cuneiform.
Okay. Does this change your opinion? Yes or no? It may or may not.
I'm just taking a moment to have a look at the images, sir.
Mhm.
So, and mm, I do not find anything additional to the. Actually, now I can see that, yeah, the joint space, whichever was appearing reduced, is similar, but I'm not able to clearly appreciate the subchondral cystic changes, which I was mentioning previously in this. But the other visualized bones are also appearing grossly normal.
Okay.
So,
So what
I
is
would
the pathophysiology of osteoarthritis? What are the okay, forget
pathophysiology.
that. What are the hallmarks of osteoarthritis on imaging, on X-rays?
On X-rays, sir, for osteoarthritis, predominantly, initially, there will be first a reduction of the joint space will be there.
Mm-hmm.
In the early stages, there might be a mild joint reduction, some amount of marginal osteophytes, some sclerosis along the articular margins, some subcortical cystic changes, that is because of the degeneration of articular cartilage along the joint surfaces, there can be some subchondral cystic changes, and in the chronic
Okay.
stages there can be complete loss of joint space.
Okay. All right. Okay. And what is the typical distribution of osteoarthritis
It is
in hand and feet?
no. Osteoarthritis typically occurs at the areas of pressure, sir, where there is more weight bearing or more pressure related areas. So
Well, hand is not a
in the foot,
weight-bearing area, is it?
no.
Okay, so
Yeah,
that's
it is
not the
not.
way I would put it, right? Hand, I don't stand on my hand, so it's not a weight-bearing joint. What is the typical distribution?
Mm, me, along the medial joint spaces,
Okay,
typically.
don't worry. We will come back
Mm,
to this. Do not worry about it. We will come back.
okay,
There's okay. Don't. This is just a teaching session. This is just a teaching Viva. Okay. So
sure, sir.
we have. Okay. All right. Hold on. Let me bring up all the images. Okay. So there's one here, and there is one there. Okay. Tell me what you think.
Yeah, I'm presented. Firstly, I'll be talking about the X-ray of the pelvis with bilateral hip joints, radiograph of the pelvis with bilateral hip joints, and in the given radiograph, I can see. I'm trying to visualize all the bones, the sacroiliac joints, and the visualized vertebrae. And initially, I can see that the major abnormality is along the the left femur, that is the proximal metaphysis of the left femur, where there is a fracture, displaced fracture involving the proximal metaphysis of the left femur. And I'm just trying to have a look at the other bones, if there are any other associated pathologies. I can see that age-related changes, that is degenerative changes, are noted in both the hip joints as well as both sacroiliac joints, predominantly on the right side. I am trying to look, since there is a fracture which is present on the femur, I'm trying to rule out if any other acute pathology is seen in the other bones. However, I cannot see any obvious displaced fracture in this radiograph. I'm unable to clearly visualize the sacrum, the lower end of the sacrum and coccyx. I think that is
Sacrum and
because of
coccyx are fine. They're fine.
of
Concept, tell me what you think of the fracture. There's no other findings. Don't worry about osteoarthritis and everything. What do you think of the fracture?
Sir, because there is presence of a generalized mild decrease in bone density, because I can see the trabeculae prominently. I am thinking it in terms of fracture because of decrease in the bone density. So that is
I think the bone
uh,
density is pretty decent for a 77-year-old female.
okay. Um, okay. So okay, then the other thing is I would like to in the proximal fracture fragment which is visualized, that is on the lateral view of the radiograph which is provided. I can see that some ill-defined lucency is noted along the
There's no
proximal
underlying bone
fracture
lesion.
bone
No
lesions.
underlying
Okay.
bone lesion.
And I can see that there are few calcific foci which is seen in the left iliac fossa, sir. So considering it to be
Ignore them.
um,
Completely ignore them.
okay.
I want you to just
Um,
talk about the fracture. Tell me what you think.
since it is a normal
Okay.
density, there is no other bony lesion, and there is a
Okay.
fracture with the distal fragment displaced medially. Um,
Okay.
I'm
All right. I tell you what happened. So the clinician looked at the X-ray. This was an A&E. She came in. The clinician looked at the X-ray and then decided to X-ray her right femur as well. Ignore that. That's her right femur.
yes. So in the provided X-ray of the right femur, I can see that the cortex is appearing thickened, sir. The cortex is appearing significantly thickened, diffusely, um, slightly more prominent in the distal aspect along the lateral cortex, but I can see that there is a diffuse cortical thickening which is there along the entire aspect of femur. So, if considering it to be a case of in this patient, it can be a case of hypertrophic primary osteoarthropathy. I would
Okay.
like to, sir,
All right. Okay.
uh,
I
I
think we're
would
going
like
to,
to
yeah, go on. Go on. Finish the case.
I would like to delineate the causes for this condition. Like primarily, it is because of the lung condition, like bronchogenic carcinoma or chronic lung diseases, or it can be because of heart diseases or chronic in extrapulmonary causes, or it can be because of chronic long-standing diseases in the abdomen, like IBD or cirrhosis. So, I would like to know the previous history of the patient, which has led to this,
Okay.
led to, and I would like to
Okay.
inform the findings. Yes.
Okay. All right. We're going to stop there. Okay.
Okay.
We'll go in reverse for the cases. Okay. Actually, we'll go on the communication part first. Okay. This is a good, this is why we love Dr. Sami Khan's DKT teaching. Okay. Because this is where we iron out our exam is not just about knowledge. Exam is also about presentation and showing that knowledge in the right fashion. Okay. And the last case is actually a very good example of it. You obviously know about hypertrophic osteoarthropathy and things like that. But in my limited experience as a musculoskeletal radiologist, I've never seen hypertrophic osteoarthropathy affecting the femur. Okay. So it would be a very, very, very exceptionally rare case. Okay. You kind of like, I felt you were very nervous, and that's okay. This is part and parcel of us doing these Vivas, because that's where we iron out how to get. I always tell my trainees when I was in UK, I would tell them, exam is a game, right? It is a game. You're going there, I used to go for my Vivas mentally preparing not just for like to answer the question, but I would be going in there with like, this is a game. You're going to throw things at me and I'm going to throw them back at you, right? You're going to show me a case and I'm going to hammer that case to the best of my abilities. It's a game. It's a mental game as well, because believe me, we had the worst type of exams where we used to go into the Royal College in the old building. We would be sitting in the dungeon for 1 hour with these other nervous trainees, some of who would be like more nervous than you, and then you go for your exam. So it just adds to that horrible feeling, right? So you have to figure out how to cope with it. And if you can't figure out how to cope with it, you're going to go into the Viva and you're going to start talking and talking and talking, and the examiner is going to be like, this person does not know what they're talking about, okay? So slow down when you are describing the case. Okay, slow down. Really control how you're speaking. Speak slowly, speak methodically, speak in a very calm, try and calm yourself down. Okay, that's the only feedback that I would give you. And the second feedback is, if you ask a question of an examiner, stop. Don't talk over him, expect him to answer, because I wanted to answer and then I'm like, she just asked me a question and now she's, like, am I supposed to answer or not? Right? So that's the feedback in terms of the communication part and presentation part. This is actually an Aunt Minnie of a case. This is a type of an insufficiency fracture, but this is the type of insufficient fracture where the bone density is normal. And I tried to give you a hint. I said a 77-year-old female, a female. This is a bisphosphonate fracture, okay? And the imaging appearances are fairly typical, okay? So they get these fractures in the proximal, they get it like within 4 or 5 centimeters of the intertrochanteric line, okay? The fractures, usually the insufficiency fractures usually starts at the lateral margin, which we saw on the other side, okay? So they'll start there, okay? And there's literally no specific history of trauma that these patients come in. It's like a minor trauma and then the bone goes, okay? So this is a very classic appearance, right? The bone density looks pretty normal because they're on bisphosphonate, but it is an insufficiency fracture in reality, right? So this is a bisphosphonate fracture. And the clue, even if you were not sure about that, the clue was in this radiograph, okay? So yeah, there is periosteal thickening, and there's periosteal thickening in almost the same level as the contralateral side, because this patient has got an insufficiency fracture, which I can show you here. Because if you had done that, then I would have shown you the CT scan, which would have shown you the fracture, okay? So this is a bisphosphonate insufficiency fracture. Unfortunately, this becomes a clear fail. There's this like a zero, you get a 0 on this case, okay? Because you couldn't answer the question right. The second one, again, one of the things that I would say is, and so the way I went for my Vivas, right? If I was 100% conclusive that this is, like, for example, I see a case of rheumatoid. Now I know it's rheumatoid, right? There's no other differential for it except for rheumatoid. So what I would do is I would say it's rheumatoid, and then I would describe the findings with a lot of confidence. And sometimes I would say there's this, and that, right? But in this case, you kind of felt very confident, but your confidence was completely off the chart, right? You were absolutely confident this is a chronic sort of a pathology. This is anything but chronic. There is intramedullary signal change, there is periosteal reaction, there is a scalloping of the bone, but the bone still looks very irregular. So this is anything but a chronic process. It may still be a chronic process, but you cannot completely exclude an acute or a more recent pathology. This patient has come in with 2-month history of slowly progressive swelling, right? Yeah, it could be tenosynovial giant cell tumor tendon sheath, but you have to keep other differentials in mind. You have to keep some sort of a bone tumor in mind. You have to keep some sort of infection in mind as well. You'd never mention infection. You never mention any other thing. This is actually an interesting case because you would look at the frontal view and you think you're dealing with an inchondroma, and then you go on the lateral view and you're not dealing with an inchondroma, and then your mind starts playing games with you. So now you have to think of proper differentials. This periosteal reaction, and it's not exactly a lamellated periosteal reaction. It's actually kind of like almost like a sunburnt, a sun ray sort of a periosteal reaction. So this is an aggressive process that's happening, not a typical for tenosynovial giant cell tumors tendon sheath, which are fairly indolent sort of tumors. Could be an infection, yes, but this actually turned out to be a metastatic deposit from a lung primary. Okay, this patient had a lung primary, and this was a metastatic deposit. So You went down on the very wrong tangent right from the word go, and then it was like literally no coming back from it. You kept on insisting, this is chronic, this is chronic, this is chronic. This is not chronic. This is actually a more recent, not very acute, but a more recent process that's going on. Okay. So unfortunately, you failed that one too. And the last one actually is an interesting case because it shows not subchondral changes. These are erosions. Okay. These are actually erosions. Okay. And when you start seeing erosions with normal bone density in atypical joints, there are very few differentials that come to your mind. Okay. And then one of them would be gout. Okay. PBNS would be one differential where you can see erosive changes, and in the late stages you see loss of joint space, but to get bilateral PBNS would be kind of unusual. So this is actually a case of gout. This is not osteoarthritis. I don't see any osteophytosis. I don't see any other evidence of osteoarthritis. I know it's not a typical location, but that's the whole point. I need you guys to think a little bit differently, right? These are visible on the oblique views as well. That's why I put them up. This is erosion. This is not subchondral cystic changes. This is not typical for subchondral cystic change and osteoarthritis. These are actually erosions. Gout this is gout, erosions in a very, and the reason I actually showed you this was because on the first case you said, atypical appearances around a joint, possibly gout. So I'm like, okay, this person knows gout. I'm going to bring gout into the picture and see what this person tells me. Okay, but this is not osteoarthritis. Osteoarthritis, you can put it as a differential, but it would not be my primary differential. Primary differential would be some gout or some other erosive pathology. Okay.
Yes, sir.
All right. Candidate number 3, please.
Hello?
Yeah, I can hear you. Can you hear me?
Oh my, yes.
Okay, all right. So I'm going to show you a very good case. You can take control if you want to. There are 3 images. Tell me what you think.
Okay, control, I don't know from where I can get. No?
I haven't received the request.
I don't know from where. Anyway,
Yeah, please go on.
I am presenting a radiograph of skeletally mature patient of hand, frontal view. I can see narrowing of the shaft of the visualized metacarpal bones associated with the irregular surface of the carpal bone and irregularity in the articular surface of the metacarpal joints and the radio and the ulnar carpal joints. This is the texture of the bone is seen normal. This is maybe one of the there is also soft tissue, large soft tissue swelling seen involving the diffusely seen around these joints. This is maybe I may think this is maybe edema. This is maybe a soft tissue edema with the underlying joint affection.
Okay.
Style.
Let me put up another view.
Okay.
Yeah, there you go.
Sorry. This is it looks actually like the edema due to this clearance of the lymph nodes in the patients of breast cancer patients. Also,
Okay.
the other possibility, the filariasis also can give unilateral limb, soft tissue swelling and edema. However, it's more common in leg.
You mean elephant leg?
Oh, elephant leg. Oh, but
Yeah.
I didn't see it before in the hand,
No.
actually.
No. So when you say filariasis, I'm assuming you mean elephant leg, or
Yes.
yeah. Okay. All right. Okay. That's not what it is, but I'll buy that for now, but that's not what it is. We'll come to that. Okay. Any other differential?
Like lymphatic, also a lymphatic infiltration in post-operative patient breast cancer, and this
Okay.
I don't remember the name.
Okay, let's just briefly discuss this before we move on. When you say lymphatic obstruction, right? Would you think that the lymphatic obstruction would affect from the MCP up to the distal forearm and spare the fingers and the proximal forearm? Would that be something that would suggest? I would expect lymphatic obstruction to have a gross swelling of the entire arm. Is that a fair enough comment? It's the entire arm. Okay.
It's more all the limb arm.
Okay, and the second question, and this is me trying to not to like discount what you're saying, but me trying to teach you some things, right?
Yes, sure.
Do you think it's reasonable to say that there is scalloping of the bones in this patient?
Yes, there is scalloping of the bone, and I think may also what causes scalloping in the bone, but more on the distal parts of the hand, there will be scleroderma, and also the skin will be tightness, not edematous. So that's why I didn't I excluded this scleroderma.
Okay, no, that's fine. The reason I'm bringing up this part is in a patient with, so I want everybody to understand when you give the differentials, right? You need to have some sort of a thought process behind the differentials. And our general tendency is, and I'm as guilty of it as anyone else. When I was preparing for my exam, I went for a few courses, and all the examiners had one thing in common, and they said, please don't speak too much, right? Just speak the relevant things, because I would get nervous and then I would start speaking or giving unnecessary differentials. This is how I learned, and this is what I want to teach you guys. If you have lymphedema from breast cancer, right? You would have to have it for months and years to actually cause this degree of scalloping. Is that correct?
Yes.
That's a lot of scalloping, isn't it? So it's unlikely to have breast cancer causing lymph obstruction, okay, causing just a selective part. Anyway, let's move on. Okay, I'm going to give you another case. Okay, we've done this case. Okay, and let's go for this one. Tell me what you think of this X-ray. So this is, I don't have the age available. There are multiple X-rays. I'm going to show you this frontal view first. If you want, I can show you the others. Tell me what you think. I don't have the age. Sorry for that.
Yes. I'm presenting bilateral hands frontal view radiograph. I can see a marked dislocation and subluxation of all carpopharyngeal joints in both hands. This is associated with normal articular surface. No, not normal articular surface. There is a erosion seen in the articular surface of metacarpopharyngeal joints. Also, there is subsclerotic changes and narrowing of the joints of the carpometacarpal and intercarpal joints. This is advanced the first differential diagnosis as it's a proximal small joints affection. It is advanced rheumatoid arthritis. Next step will be review other joints, review the other joints and previous radiographs for other appendicular joints. Also will also will ask for rheumatoid factor and CRP investigations and rheumatology MDT.
Okay. All right. Okay. Stay with me on this case.
Okay.
So what do you think of this case then? This is the case that we've just reviewed, and this is the case that I've just put up. What do you think of this?
This is another case.
Okay. Do you see something?
This is another case. I found there is a dislocation and subarticular also sclerosis. It looks like the same diagnosis, but this
Okay.
one has also a distal interphalangeal joint affection. This is maybe erosive arthritis. But
Okay. All
actually,
right.
or rheumatoid arthritis also, because the proximal joints are also severely affected.
Okay. Let's come back to this case. Can you point out where the erosions are?
Point, I'm not sure, like, if I can take the.
Try and take control if you can. Am I getting a
From,
request?
I
No,
don't
I'm
know
not getting a
exactly
request.
from where I can get the request.
It usually is. I'm not sure, to be very honest, because I'm actually. Let me see if I can give you control, remote control. Candidate 3. Okay, candidate 3. I'm just waiting for you to take screen control.
Okay.
Okay. Have you got it?
Yes. I
Okay.
can you,
Yeah.
sir, see now?
Yeah, it's not moving, but tell me where you see these erosions. I'm
Ah,
interested in seeing the erosions.
okay. I see this. I think this area. It's the interpharyngeal joints, the metacarpopharyngeal joints, the articular surface of the phalanx, the proximal phalanx is not clearly seen in
Okay.
this
All right.
this joint.
Okay,
So
we'll come
that's
back to
why.
this one. We'll come back to this one. Not a problem. I just want to show you one more case before we go on the feedback. Okay. All right. Okay. So this is a patient, okay, who has come in, and this is me telling you exactly the way it happened. This is a patient who's come in to the clinic. You're on duty for MSK ultrasound. And this is a patient who's come in, referred by the orthopedic team for an injection into her ankle because she is in pain. Okay. And she's come in with her daughter and she's in a lot of pain. And you are about to inject you're about to do an ultrasound guided injection in her ankle. What do you think?
I can see this is an ankle radiograph, frontal and lateral view. I can see a soft tissue swelling seen in the at the area of the middle malleus.
Okay.
And this is I wanted to I can see also screws down near
Ignore it.
okay, fine.
Ignore the
Um,
osteoarthritis at the midfoot. Ignore the
okay.
screws. The soft tissue swelling is actually subcutaneous lymphedema related to mild heart disease. She's got a history of mild congestive cardiac failure and some chronic venous insufficiency. Ignore all
Okay.
those three.
Okay. Can I just make more focusing? I want also to check the joint surface is seen intact. The tibia and the fibio and tibutalar are seen intact. There is changes seen in the cortex and the medulla of the fibula, distal end of the fibula.
It's perfectly fine. Mild sort of
Fine.
osteopenia, nothing, not Paget's, nothing to worry about.
Okay. There is maybe there is a stress fracture seen in the calcaneus body
Nope,
as a line. No,
nope,
this line
nope.
of sclerosis is not
If you're talking
fracture.
about this line of sclerosis, that's
Oh,
just
yes.
the sustentaculum tali of the,
Okay, fine.
that's just the sustentaculum tali.
Okay.
There's no correlation either, by the way. So
Okay. Then
she's in a lot of pain. She's actually literally, her daughter had to, she's come in, she's not able to bear weight actually on her foot. She's in that much pain, and her daughter had to bring her in a
there is
wheelchair from the
actually
parking lot.
feeling. There is, I'm not sure, but there is a feeling in in the cortex of the navicular bone,
Navicular
and
is fine.
it's fine.
Yep.
Mm,
Patient is 63-year-old
okay.
female.
63.
Female.
Mm,
Anything else? You don't have much time. So,
the thing is, like, I can't actually see. I can't see a definite pathology.
okay. All right. Okay. Have you looked at the bones properly? We say we look at the bones properly, but we honestly don't look at the bones properly. We sometimes miss
Uh,
important things. And I've given you the history, which is very helpful. Have you looked at the bones
yes, I
properly?
can see actually also the tibia, the tibial surface in the tibiofibular joint is seen ill-defined. The
No,
cortex is
it's
seen
just
ill-defined.
projectional and a bit of osteopenia. No.
Mm, the bone,
Okay, all right. Let me point out to you.
so you
Okay.
can see.
Let's start
Okay,
off here, shall we? Okay, we'll do it together.
okay.
Okay.
Mhm.
You're going there, you can see the cortex, see the cortex, see the cortex, see the cortex, see the cortex. What's going on here?
Oh, there is a periosteal reaction
Okay.
seen.
All right. Let's
Periosteal
go on to the
reaction
lateral
seen.
view. See the cortex, see the cortex, and then what do you see here?
There is a periosteal reaction of
Okay.
the.
All right. Okay. We're going to stop there because otherwise you're not going to be able to get the feedback. Okay. So this is actually a genuine case. I'm not kidding. This is a patient of mine that actually turned up in my clinic, had an X-ray done, which was not reviewed properly. I'm not saying it's the easiest X-ray to be done, but it is there. So she came in, she was in a lot of pain. She was literally not able to bear weight. And I looked at her and I said, this does not feel right. Looked at the X-ray and I was worried about something else. So what's the next thing I did? I literally took her around, begged and
MRI.
pleaded and tried to get the radiographers to do an urgent MRI right then and there. What is the finding?
Stress fracture.
Correct. Okay. So this is a stress
Mm.
fracture. Okay. She's
Oh,
63 female. She's in a lot of pain. Okay. There is periosteal reaction there. This was a stress fracture. Okay. And
mhm.
she was immediately sent to A&E. Obviously, they're not going to do anything surgical. She just needs a boot, a plaster or something to immobilize her foot. But this is a stress fracture. Okay. So again,
Oh,
just we say we look at the bones, but we really don't look at the bones. When you're talking about looking at the bones, you must look at the periosteal reaction, which you can clearly see here.
mm,
Okay,
oh,
so it's a stress fracture. The second
mm.
case actually is I kind of showed you Aunt Minnie's. So, all right,
What?
okay, yes. So
Mm.
this is what is the diagnosis? I'm going to look at the chat. Has somebody put the diagnosis there? What's the diagnosis for this case? Well done to Angam Saleh. Neurofibromatosis. Okay. This is an Aunt
Oh,
Minnie. Okay. If you've never seen it before, see it now
uh,
and just memorize it and make sure that you never forget it. Okay. I have
uh,
seen only one case when I was doing Viva, and this is the only case that I've got in my collection. Okay, this is a classic Aunt Mini. A lot of soft tissue swelling, gracile bones with a lot of scalloping because the soft tissue has been there for a
oh,
very, very long time and it's affecting the density of the bone as well as causing scalloping of the bone. Okay, this is an
uh,
Aunt Mini. This is neurofibromatosis. Okay, and this is a
uh,
large, big, giant plexiform neurofibroma in this patient. Okay, look at the soft tissue here. Look at the soft tissue there. There's nothing going on there, but this is completely abnormal. This is not me. This is not nothing else. All right. The second case is actually also kind of like an Aunt Minnie. Okay. Now you actually told, I think people look at this and they start thinking this is erosions. This is not, this is Jacob's arthropathy or SLE. Okay.
Systemic lupus.
Yeah. So this is the reason why I actually put this case right next to it. Okay. This is what rheumatoid arthritis is. Okay. Yeah. They both have ulnar subluxation. This one also, but look at the metacarpal heads here.
This
Okay.
reversible
Irregular erosions.
reversible soft tissue swelling. Soft
Yeah.
tissue
This is all.
subluxation.
Yeah. This is all. There's no erosions there. There's literally no erosion that I can see. And the reason you're getting this changes here is because this is a disease which affects the ligaments, which is why you're getting this ulnar subluxation. So this patient has got scapholunate dissociation, okay, widening of the scapholunate articulation, and now the capitate basically has started to come down, causing osteoarthritis. So this is slack wrists which are developing, okay? So this is Jacob's arthropathy. It's pretty classical, okay? It is not erosions, okay? Just subluxations, all right? Okay, that's you done, okay? Last candidate, please.
But you didn't give me a mark, doctor.
Well, okay. So obviously you can't pass the Jacob's arthropathy, and you can't pass, like, they're kind of like, you describe the findings. So I think in both those cases, you're gonna for neurofibromatosis, you're gonna get borderline fail. For Jacob's arthropathy, it certainly is going to be a fail. And again, for the last case, which I think was the periosteal reaction, again, is going to be borderline fail to fail because you didn't manage to pick up the findings. Okay. So in terms of communication, what I would say is just, again, slow down. This is the most important thing that we have to do when we are sitting FRCR. Slow down, right? Just calm, collected, speak methodically, logically, slowly, give reasonable differentials. If you don't know the differentials, right? And I understand, right? Because obviously, I mean, looking at your Viva, it was clear that you had not seen a case of neurofibromatosis before, right? If you don't know the differentials, right? My advice to the trainees is maybe spend a little bit more time describing it. That does two things. Number one, it actually, there's information at the back of your brain sometimes, right? You know something, but you can't put your finger on it. You don't know how to say it, right? And by describing it, right, the bell at the back of your head starts ringing, right? And then it's just like, oh yeah, that's what it is. That's what it is, right? And then you start saying. But the second other important reason is that you literally are trying to buy a little bit time with the examiner, okay? And your brain is like in the background, it's like running at a speed of knots to try and figure out. And what that will sometimes do is it will actually help you from giving the very wrong differentials. Obviously, I can see where you're coming from in terms of lymphedema related to previous breast surgery and things like that. But then when you're talking about it, you're describing and you're saying, oh, there's soft tissue swelling there, and your mind is telling you, there's probably previous surgery and that's why there's lymphedema. But then your brain in the background is saying, hang on, it's localized from the metacarpals up to the mid forearm. The proximal and the distal parts, the soft tissues look completely normal. So it can't be subcutaneous lymphedema related to surgery. Go find something else, right? So you don't have to rush in from the very first 5 seconds to this is the differential. Take your time, describe it. If you don't know, it's a balance. If I show you, and this is an example for all of us to learn from, if I show you this case, right? Okay, I'm showing you this case. This is rheumatoid arthritis. What you don't want to do is sit for 5 minutes and waste 5 minutes of your time describing rheumatoid arthritis. You should literally start off by saying there are erosions at the carpus, metacarpal joint, interphalangeal joints with ulnar subluxation, osteopenia, penicillin cup deformity. These imaging appearances are most consistent with rheumatoid arthritis. I would like to have previous imaging to compare whether there's any progression of the disease. Patient needs to be referred to rheumatology, MDT, if the patient is not already under the care of the rheumatologist, blah, 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 right? 30 seconds, 1 minute, right? But you know the diagnosis. But in cases where you don't know the diagnosis, describe. Let the differential come to your brain if it's there. But in the case that you have not seen like a neurofibromatosis, even if you don't know the answer, you may be able to give some sort of a reasonable answer that the examiner is like, okay, fine, they didn't know the answer, but they give it a very good shot, and that puts you in good stead. Okay?
Okay.
All right, candidate number 4.
Hello, sir. Good evening. I'm
Good
candidate
evening.
4.
Okay, candidate 4. All right. Okay. Let's start off with this case. And I'm going to show you both the images. Okay.
I've been presented with frontal and oblique projections of a skeletally immature patient of the right lower limb, where I can see there's the visible deformity. There is deformity involving the shaft of the right femur. Besides that deformity, I can clearly appreciate a transverse fracture with sclerotic borders around and surrounding callus formation along the proximal diaphysis. In the other oblique radiograph, I can also appreciate some dense metaphyseal bands in the distal femoral distal metaphyseal regions. I cannot appreciate any other abnormality. To me, the bone density in this particular radiograph appears to be slightly reduced. Now, however, I would confirm this finding by comparing it with the other radiographs of the patient as well, if available. So if the patient is, I'll correlate my findings with any given history. If the patient is having a known bone disease, my top differential would be osteogenesis imperfecta with presenting with fracture. In that case, I would be evaluating rest of the bones as well, because the patient might be having other fractures as well. For I'll also I cannot appreciate any epiphyseal changes. So yes, osteogenesis imperfecta. I cannot appreciate any background abnormality within the bone to within the medullary or medullary region to give a diagnosis of any pathological fracture.
Okay, here's a question for
And
you. These dense metaphyseal bands, what could they be related to?
so these can be normally they can be a normal physiological finding as well. However, if the patient is on therapy for his underlying disease process, these can appear because of that. In rickets also, we can see dense metaphyseal bands. But in this patient, if the patient has a known diagnosis of osteogenesis imperfecta presenting with this deforming bending of the femur with fracture and these dense metaphyseal bands, it can be because of underlying ongoing therapy for his disease process.
Okay, all right. We are going to move on to the next case. Okay, can you take control of the screens because you may have to scroll?
Sir, unfortunately, I'm unable to find the option. It's not coming beside your name. Usually it
Okay, hold
does.
on.
I'm sorry.
No, don't worry. I'm just trying to give you the control. There you go. Okay, no, hold on. You've got the wrong button.
Sorry.
Hold on.
Sorry.
No, don't apologize. Nothing to apologize for. I would use the arrow keys for scrolling. Okay, so this is a 62-year-old patient who's come in with back pain. There are scout images and there's sagittal T2, sagittal T1, and axial T2. Hold on. I think you
Sir,
need to
let me the arrow
don't use
key.
the mouse. Don't use the
Okay,
mouse. Use the arrow keys.
I'm sorry.
No, don't worry. If you want to use the mouse, you can use the mouse now because I've changed
But
the
I
setting.
guess that's the mouse is not scrolling it. I'm trying to scroll it with the keys.
Okay.
Is it me or is it you?
Have you still got control? Can you move the mouse? Yeah, you still got control because you're moving it. Okay. Do you have a scroll wheel on your mouse? Try that.
Sir, I'm on the laptop and I'm trying with the arrow keys. It's enlarging
Okay,
and minimizing, but
okay, then try the other two arrow keys.
no, this changes the.
Okay, you should be able to use the scroll mouse then to.
I'm
There we
not
go.
Yeah.
Oh, you just, yeah, that's fine.
Is it
Okay.
me or is it you? Is it
No,
me?
you're
Yeah.
scrolling. You're
Okay.
scrolling. Yeah.
Okay. Thank you so much. Thank you so much.
Hold on. Hold on. Yeah, go on, please.
I'm sorry, I'm still struggling. I'm trying to adjust. I'm not sure. Why is it
Okay.
giving?
All right. Okay, let's take away this case then. Okay.
I'm so sorry.
No, don't worry. Don't worry about it. Don't worry about it. We'll get you a good case. Don't worry about it. Okay. All right. So this is a, let me just reset it and scale to fit. Okay. What do you think of this one? Hip pain.
So I've been presented with a frontal radiograph of a pelvis of a skeletally mature patient. In the first instance, I can see there are multiple lytic areas involving the pubic rami bilaterally. Also, I can see some lytic areas involving the left femoral shaft, neck, and head. Bilaterally hip joints otherwise unremarkable. I cannot appreciate any gross abnormality in the iliac crusts or the iliac wings. I cannot appreciate any fracture line. The visible vertebrae, transverse processes, and the visualized part of the sacrum appear unremarkable. So coming back to the findings, these are multifocal lytic, small-sized lytic lesions involving the said regions. If the patient is of older age, my top differential in with these deposits would be metastasis if there is a known malignancy, since these are lytic. So I would evaluate the patient for breast if it's a female, or it can be from the lungs, kidneys, or thyroid. However, besides the metastasis, I would also keep myeloma is in my differential. For that, I would like to check if the patient has undergone any screening for that. I'll immediately inform the findings to the referring physician, and the patient needs to have a screening for multiple myeloma, including
Okay,
seroma
can I stop you? Can I stop
Sure.
you?
Sorry. Yeah.
Okay, all right. Number one, can you point out where you see the lytic lesions in the pubic bones?
Now, are you able to see my arrow?
No, I can see it moving. Yeah,
You can see now?
yeah. These are just
There is
projectionals.
all
Just
of
projectional.
these,
Yep, these are just projectional. Okay.
and
What about
all
any other
these.
Yep, just projectional. Any other
These are all
areas?
projection.
Yep, these are all just technical.
Okay, let me get back
Okay,
to the
let me tell you
experiment.
something. Let me tell you something more importantly. Patient is only 29 years old.
Okay. I'm reviewing my findings again.
Yes, please do.
Thank you. Okay. 20-year-old.
29.
29,
Okay.
29-year-old.
Yeah, 29-year-old.
Okay. I can appreciate patient has undergone some contrast study where I can see the contrast and the distal ureters. If
Ignore
that's
it
relevant to
completely.
my, sorry?
No, ignore it.
No,
Ignore it.
ignore.
Ignore it.
Okay. Um, okay. 29-year-old, for the sacroiliac joints.
Completely normal.
Medial medialization.
Can
So,
other candidates please mute themselves if you don't mind? Thank you. Yeah, go on, please. Candidate number 4.
Thank you. So, there's some faint ossification along the, I can appreciate, I'm not sure if it's projectional again, on the lateral aspect of on the right side, along the gluteal muscle.
Okay, I'll give you a hint. Patient is complaining of left hip pain.
So on the left side, I'm looking at the bones first. The iliac bones appear normal. Femoral head is well shaped, non-sclerotic, non-flattened. The acetabulum appears fine with some areas of overgrowth, likely early osteophytes along the superior margins. Lesser and greater trochanter's on the left side appear normal. Medullary cavity of the femur appear normal.
Okay, all right. Okay, let me take control. Okay, right hip, right femoral head. Any abnormality? Any bone density changes? Anything going on there?
The acetabulum margins are very subjectively sclerotic.
Which side? Right side is normal. Right side
The
is
right
normal.
side, then the left side is also okay. If the right
Okay.
side is normal.
Look at the right femoral head. Everything good? Now look at the
Looks
left
good.
femoral head. Does that look good? Look at the right acetabulum. Look at the left acetabulum. Look at the bone density here. Okay. And look at the bone density there.
Right, sir.
Okay. All right. Okay. We'll come back to this case. Don't worry about it. We will come back to this case. Okay. All right. We've done that. Okay. All right. Let's show you. Because you can't scroll, I am kind of limited. Okay, but this is a good case. Hopefully you. No, don't worry about it. Don't worry about it. We still have good cases. So we have to stick with plain films. Go on.
Is it the same patient, sir? Oh,
No,
okay.
it's a different patient.
Okay, yeah. So, lateral skull radiograph of a skeletally mature patient. I can appreciate multiple variable-sized lytic lesions diffusely spread across the calvarium with some sparing of the occipital region. I cannot appreciate any significant calvarial destruction in this, no soft tissue or scalp swelling. The spine, upper cervical spinal vertebrae have some osteopenic changes. However, I cannot appreciate any significant pathological fracture. Rest of can I please know the age of the patient?
55 years old.
So right. The posterior occipital area has also got some focal area of lucency in a rather well-defined fashion.
Ignore that.
So, okay. So the only finding that I can see in this, these are these multiple variable size lytic lesions diffusely spread across the calvarium without any associated soft tissue. So keeping in view the age of the patient, my differentials would be METs versus myeloma. Since the density of the cervical vertebrae on this particular radiograph is also somewhat osteopenic, so I'll consider a multiple myeloma as well and would like to screen the patient for myeloma as well as METs. And
how would you screen the patient with? How would you screen the patient for myeloma? What are the guidelines these days for UK for screening patients with multiple myeloma? And what other, from imaging perspective and non-imaging perspective, I want to know both.
Okay, for non-imaging side, we can do the Benz-Jones proteins and serum electrophoresis, while for imaging purposes, we can do a low-dose whole body CT or MRI.
Okay, all right. Any other differential for this case?
And also,
could this be, okay, here's my question to you then. Could this be hyperparathyroidism?
Exactly, I'm thinking on the lines of hyperparathyroidism as well, because it can also give multiple lytic raindrop kind of appearance. And if the patient has got a known history of chronic renal failure, that would be my top differential as well for this pepper pot appearance.
Okay, all right. We will come back to this case. Okay. Okay. Let's look at this one. Default. Yeah. So patient with left hip pain. Actually, I'll just leave it at default. Yeah. Patient with left hip pain.
X-ray frontal projection of a skeletally mature patient, X-ray pelvis of a skeletally mature patient, where I can see a displaced and avulsed left ischial tuberosity, which is giving an irregular sclerotic margins. There's also the parent bone of the left side also appears irregular. Besides that, I'm looking at rest of the bones. There's also an ossification along the medial aspect of the right femoral neck, and I would like to. It is within the soft tissues.
Can you point it out?
Can you see my? Oops.
Yeah.
This one.
That's vascular.
Okay, so the prime pathology that I can see, I cannot appreciate the sacrum appropriately in this windowing, and if
Sacrum is fine.
Yeah, with windowing we can have a look. Otherwise, if it's fine, I cannot appreciate any other abnormality. So this if the patient has been having a pain for a pretty long period of time, this may represent a neglected eversion fracture of ischial tuberosity on the left side. Because there's also irregularity of the ischial tuberosity itself, so that would be my top differential. Otherwise, for the calcification overlying a soft tissue with this configuration, also myositis ossificans would also be in my differential list if there is a history of trauma. And these findings need to be communicated to the referring physician. Patient can be further evaluated with a CT for confirmation of the finding, and orthopedic referral or fracture clinic can further be informed about this patient.
Okay. Anything else? Before we move on to, you may have time for another case. Anything else?
So, the femoral necks, femoral shafts appear normal. I'm not very happy with the windowing of the femoral heads, so I cannot comment on the sclerosis that is visible over here.
I think femoral heads are absolutely fine, but I've windowed it a little bit if that makes a difference.
Sacrum, lesser trochanters are fine, greater trochanters are fine, femoral necks. I cannot see any asymmetrical cortical thickening along the medial or lateral aspect of the femurs bilaterally. Yeah, the trochanters, greater trochanters are fine. Iliac bones, iliac crust and wings, as seen in this window, appear unremarkable. I cannot clearly see the sacroiliac joints, unfortunately.
Fine.
And
sacroiliac joints are fine. Okay, I'm going to show you one more case because I want you to make the most of this. Okay. And then what I'll do is just for everybody in the group, I'm going to put up a case. Okay. And whoever gives the answer first gets his name called out on the session. Okay. But once we're done with the Viva, just one case, just one case. Okay. Go on, please.
I've been presented with a frontal radiograph of abdomen, including including the lumbar and lower dorsal vertebrae and the pelvis. The first thing that I can see is a patchy sclerosis and mild deformity of the right femoral head as compared to the left side. Also, the lumbar vertebrae have somewhat depressed superior and inferior end plates, giving an appearance of H-shaped vertebrae. Sacroiliac joints, iliac crusts appear normal. Pubic bones bilaterally appear normal. Trochanters appear normal. So I would like to correlate my findings with there's some sclerosis apparently of the ribs as well, but I would definitely check other radiographs to confirm my finding, because there's patchy density of the visualized vertebrae as well. So I would like to know if there is a diffusely increased bone density of the vertebral body and the ribs, or if that is just projectional for the ribs. Because for the pelvis, the density appears to be normal, except the femoral head I've described. The bowel patterns that I can see
It's
is
completely normal.
no, yeah, it's non-specific and normal. I cannot appreciate any radio dense region in the right upper quadrant or the flanks. The pedicles are visible. The spinous processes are fine. Transverse processes. I cannot appreciate the transverse process of the L4 right, but that can be
It's
because of the
completely
overlying.
fine.
Yeah, that can be because of the rest. I cannot appreciate any other abnormalities. So I would like to the differentials on the findings of this patchy sclerosis of the right femoral head. I would like to know the history of the patient. If the patient is young and having a right-sided hip pain, this can be early stage of right femoral AVN, where I cannot appreciate significant osteoarthritis at the moment, but some patchy sclerosis and lucencies are there. And the presence of H-shaped vertebrae in this projection with these findings makes me think of sickle cell disease. However, I would correlate my findings if there is any prior imaging available, or if there is any prior history of any hemoglobinopathy.
Okay, we're going to stop there, okay? Because I'm going to lose my train of thought, what I want to say, okay? So we'll go in reverse, all right?
Yes, sir.
Now, you got this case. It's sickle cell disease. You got it. I think
Sir.
sometimes we are too obsessed with giving a management plan. We are too obsessed with giving, like, we have to say something. No, you don't have to, right? You don't have to. You can just say the overall imaging appearances are consistent with sickle cell disease. I would let the clinical team know that at this point in time, I can't see any sort of collapse of the femoral head, right? And so in this kind of case, you've picked up the most important findings, right? You've picked up that there's H-shaped vertebrae, there's avascular necrosis. You've added 1 and 1 plus 2 together to give the diagnosis of sickle cell disease. You can give the relevant negatives in this case. What would be the negative relevant, bearing in mind this patient has got an abdominal X-ray? So we've done it obviously for abdominal.
I could not appreciate splenomegaly, so I would check if there is any history of splenectomy, or it can be autosplenectomy as well.
Okay.
Or there is definitely no AVN, definitive AVN on the left side.
Can I finish? Can I finish?
Sorry, yes.
No, it's fine. Okay. Autosplenectomy is calcified spleen.
Yeah.
Okay. So not splenomegaly. You're right. You're looking for autosplenectomy. So there's no calcified spleen. That's one negative pertinent differential. The other pertinent negative differential is no gallstones. Okay. So you can give these negative differentials, right? There's no evidence of bowel ischemia. Sickle cell disease is a coagulopathy. Okay. There's no evidence of bowel ischemia. Bowel gas pattern is non-specific. These are the relevant differentials that you can give. You all must learn how to close the case. You guys are struggling, right? You don't know how to close the case. It's a trick that you have to learn. And not every case has to be given like I have to go to refer this and I'm going to refer that and I'm going to refer this. A lot of these patients are actually, you can just say, I can't see any evidence of bowel obstruction. I don't see any gallstones. I don't see any autosplenectomy in terms of calcification of the spleen. I'll let the clinical team know that at this stage, all I can see is chronic changes of sickle cell disease. I'll let it be. Okay, and there's no collapse of the femoral head. Not every case has to be given a certain, what is the management of these patients? They're going to be treated conservatively. Nobody's going to go and operate on them. They're going to be rehydrated and they're going to be just treated with pain relief. Okay, so yeah, just be mindful of that. Learn to see where the case ends. This is unfortunately a clear fail. And this is a difficult case for me to define. I was reflecting on how to evaluate you, right? Because you picked up the myositis ossificans, we'll come to that. But what you haven't picked up is this patient has got a big, large lytic bone lesion with soft tissue mass hiding in there. And I apologize for saying this, but you can't argue that the windowing is not appropriate. It's got nothing to do with windowing. I'm going to put it on auto windows. And even then, you can clearly see the margin, the iliopectineal line on the left side. It's disrupted. There is no iliopectineal line. And this is one of the areas where I was actually told to look when it, like, thank God for Nigel Raby. I don't know whether anybody knows his name. He's actually retired a long time ago. He was the very first MSK radiologist I encountered. And one of the very first cases he actually showed me was an iliopectineal line disruption for a fracture. So as a musculoskeletal radiologist, it's drilled into my head that when I look at the pelvis, I always look at the iliopectineal line to see if there's anything going on there. This is a metastatic deposit. This is bowel gas, but this is a metastatic deposit until proven otherwise, okay? Second thing was you mentioned displaced avulsion fracture. Okay, it can't be an avulsion fracture of the iliac bone if the iliac bone is still there, okay? Avulsion fracture means a bone fragment has sheared off. If there's a big giant bone fragment there, this is myositis ossificans, okay? You're not going to do anything about myositis ossificans. You're not going to do a CT. You're not going to do an MR. You're just going to tell the clinician, red herring, mate, myositis ossificans. If you want to take it out, take it out. If you think it's symptomatic, doesn't need any further imaging, okay? This is the most important finding here. Everybody looks at that. People then forget to look at the whole pelvis, okay? So unfortunately, this is a fail, okay? Sorry, there's no other way I can grade it. And this is a significant fail as well, because obviously it's a malignancy. So it's something that the examiners are not really going to be looking at favorably. You picked up this case, okay? And you kind of, the reason I actually asked, the two things here. The reason I actually asked whether this could be hypoparathyroidism is because it's less likely to be hypoparathyroidism. Typically, hypoparathyroidism, you get multiple lucencies, but these are all pretty much the same size. This is sometimes described as a raindrop skull. Why they say raindrop skull is because there are lucencies which are there, but they are like some tiny, some bigger, some even bigger. Okay, so they're of variant sizes. It's like water splashing on the floor, right? Maybe one drop, but once it splashes, it doesn't mean that they're going to be uniform size. Okay, so this is a raindrop skull, but you are otherwise absolutely right. Mets myeloma would probably be a bigger differential than Mets, but the two differentials were right. In terms of screening, I've never heard of low dose CT for screening. MRI is definitely the recommended imaging modality of choice. So just be aware of what you're recommending, okay? I mean, I don't think the examiners are going to mark you down for that, but CT is not the imaging modality, it's the MRI scan. And obviously you can look for light immunoglobulins and, Benz-Jones proteins and things like that. Okay, next case. Unfortunately, this was also a fail. Okay, so the abnormality is actually here. This is normal bone density. This is not normal bone density. There's an erosion going on here. There is scalloping of the bone here, okay? But at the same time, there are erosions at the joint, but the joint margins, the joint space is preserved. So what is it?
So pigmented villonodular synovitis?
Correct. This is PVNS, okay? This is PVNS. All right. So you can clearly see the same findings, okay, involving the femoral head and the acetabulum, okay. This is PVNS, okay. So if you see erosions at the joint with preservation of the joint surfaces till the end, eventually it will collapse, but that occurs very late in the disease. So that is PVNS. Okay, the last case, this one you nailed it. This one, like, excellent pass. Okay, you knew all the answers. This is pseudoarthrosis, gracile bones with reduced bone density, osteogenesis imperfecta, pretty much aren't many. These striped lines or dense metaphyseal bands related to bisphosphonate therapy. Okay, no issues here. You get the highest maximum mark that you can get for this one. Okay. Overall, in terms of your communication skills, presentation, I think you're pretty decent. Again, just same advice as everybody else. Just slow down. Just control your breathing. Control. It's very easy for me to sit here and say this. I understand. I'm not trying to judge you. I'm just trying to give you advice. Just slow down, because sometimes when you're going with a very fast train of thought, you kind of lose sight of the examiner trying to help you. You kind of lose sight of the examiner trying, and examiners are human beings, right? If they're sitting on the, chair hour after hour going through different trainees, if a good trainee comes along, they'll be interested. If a trainee that's not quite good, they might slump in the chairs. We are all human beings. That's why there is so much effort to remove any sort of bias or any sort of, that sort of a element creeping in. But you can help your cause by just slowing down a little bit, speaking a little bit slowly, taking your time, and just going through the cases in the right manner. I'm going to put a case here at the end, okay? And this is just for fun, okay? I don't know whether I have the case. I have the case. Hold on, let me just put there. Okay. If you don't get the answer, don't worry about it, okay? If you get the answer, brilliant. I want to see who gets it first, okay? Spot the abnormality. Oh, sorry, let me just put that there. Okay, spot the abnormality. Just for fun. Dr. Imran Ladakh, you don't count in this session. I think everybody picked up on Dr. Imran Ladakh's answer. I know Dr. Imran Ladakh, so yeah. Okay, has everybody seen it? No, it's not a cuboid lytic lesion. This is a rare case of an absent medial sesamoid. Okay, absent medial sesamoid. I have never seen it before. I just find it very interesting. This is congenital. It's an incidental finding in this patient. Okay. All right. Any questions? Anything? You guys are, the forum is open. If you guys have any questions, I'm happy to answer.